Do you ever wonder if you make a difference as a laboratory professional? In the laboratory, it's sometimes difficult to know the impact that our decisions have on the patient at the other end of that specimen. And sometimes we find our decisions have made all the difference for a positive outcome. Hello, I'm Sheila Black, medical technologist with over 30 years of experience in the laboratory. And today we'll be discussing detection of Naegleria fowleri. At the end of this presentation, you'll be able to understand the importance of considering the possibility of Naegleria infection with CSF specimens on suspect meningitis cases, and the critical importance of asking about freshwater exposure history when a CSF specimen is received for meningitis workup. You'll understand even with an extremely high mortality rate, there can be successful treatment outcomes with early detection in the laboratory. Become familiar with the detection of methods and steps in the laboratory for Naegleria and CSF, and you understand the do's and don'ts in specimen processing and tips for rapid detection. The first part we're going to look at is a true story of survival and displays the key role that the laboratory has in positive outcomes. The fast action of the laboratory identification of Naegleria fowleri and notification to the physician allowed for treatment to be expedited and ultimately led to a successful outcome in Sebastian's story. In any amoeba case, time is of the essence. The faster a positive identification of amoeba and CSF can be made, the faster the treatment can be initiated in suspected cases of primary amoebic meningoencephalitis, or PAM. We'll share with you best practice for rapid identification of amoeba in cases of suspected PAM. It's also important to note that PAM may not be on the radar for the initial diagnosis, and you as the laboratory practitioner may be the first to know that amoeba are the causative agent of the patient's symptoms of a severe and usually sudden onset headache, fever, stiff neck, nausea, vomiting, and disorientation. With your knowledge, hope for a positive outcome can be a reality with a disease that is 97% fatal and 100% preventable.
In the morning, he started complaining that he said, "I can't stand it, Mom. The pain is so hard that I can't stand it." And I just put some clothes on. My husband was putting some clothes on. We just dressed him and put some sunglasses because he couldn't stand the light. And he said, "Don't move me, don't touch me because it's hurting a lot."
It was, I guess, our typical Sunday afternoon. And I saw on my tracker board that a teenager had been placed in room number 5. The only thing that struck me was the fact that Sebastian was wearing sunglasses even while in the room.
We received a body fluid or spinal fluid from the emergency room, and I sat down to do the cell count. And I did the cell count and looked at it and found red cells and white cells. Nothing highly unusual, although the white count was a little high. But I put this slide off this microscope and sat down to write my numbers down. And I looked at the age and said, I'm going to look at this again. And I put it back on the scope, and I actually looked outside of the counting area where we normally count. And being aware that it's summertime and amoeba are something that it's part of our protocol to look for, but I decided I was going to spend a little time and look a little harder at this. And I looked under the scope and studied some cells for a while, and that's when I saw the movement of the amoeba. It was at that time that the adrenaline kicked in, and I had 2 co-workers come, and I said, "You need to confirm this because I need to make sure this is moving." And by the time they sat down to look at it, I was already on the phone to Dr. Hernandez in the emergency room. I told him what I suspected and told them I wanted to look at a stain slide, and I asked him if there had been water exposure, because that was something that I brought back with me from the amoeba summit that I attended last year. And then it was just a whirlwind from there.
So I started to shake and my hands started to get sweaty because I realized that if this was the case, this teenager that I had just been talking to pretty much had no chance of survival. So before I even went into the room to talk to the family, I activated the process to get our pediatric infectious disease specialist and our pediatric critical care doctor on a three-way conversation so that we could start making all the arrangements that we needed in order not to waste any time.
Having dealt with other cases of amoebic encephalitis, I knew that the mortality is pretty high.
Just knowing how fatal it was is what really got everyone working quickly and trying to really just support the family.
So I knew that really you gotta do really everything that you can, and there's no margin for error with this kid. He started on what we consider the best possible treatment.
But I knew we had to reach the CDC to get the other medicine. The thing was, I wasn't sure if it was still in town or the CDC had to ship it. So my important thing was to get that medicine quickly. So I called them anyway and I spoke to the CDC. At the same time, the medicine that we did have here in-house was started in the ER. The concept is that you know that at cold water, they don't strive. And so by cooling the body all the way down to that cold, they become cysts. And those amoebas, that's how they protect themselves, which is crazy. But they're at least not eating. And that was my concern, not to have them have the brain-eating amoeba, let them all be frozen and let us kill them. But again, you're 32, 33 degrees temperature. I mean, not many people can survive that either.
And I remember Dr. Liriano telling the parents, without letting him know what you're doing, say your goodbyes.
The doctors told me, just tell him whatever you need to tell him now. My husband went to one side of his face and I went to the other, and we were talking to him, and as he was awake, we were just saying positive words, just saying, you're our prince, you're strong, believe in the Lord, they're gonna cure you, you're gonna be fine.
Like I said, most of the cases, we have at least 50 to 100% fighting chance. This is 1%. I have to, make the family aware that this is deadly. So for me, that was hard. How do you tell a conscious child and the family that he might die? How do you do that? And so, I had to tell him, just tell him how much you love him. It was the hardest part for me.
For a moment, I said, oh Lord, if he's gonna suffer more, just take him with you. I know he's gonna be with you in heaven. I know it for a fact. But then I just said, no, you're gonna give it back to him because you promised me that. You promised me that he was gonna be saved and he was gonna be healed. And I believe in your word. So I took that back and I said, oh God, I know my son is gonna be alive. And he is.
Next, we're going to be hearing from Dr. Jennifer Cope from the CDC. Jennifer Cope is a medical epidemiologist and infectious disease physician with the Waterborne Disease Prevention Branch in the National Center for Emerging and Zoonotic Infectious Diseases. She oversees the Free Living Amoeba program, which supports clinical, epidemiologic, laboratory, and communication activities related to free-living amoeba. She's going to be talking about the history, diagnosis, and prevention techniques for PAM.
Hello, I'm Dr. Jennifer Cope, an epidemiologist and physician at the U.S. Centers for Disease Control and Prevention, where I study the epidemiologic and clinical features of free-living amoeba infections, including Naegleria fowleri. I would like to speak with you about a disease called primary amoebic meningoencephalitis, or PAM. It is a rare and devastating infection of the brain caused by the free-living amoeba Naegleria fowleri, which some people call the brain-eating amoeba. First, I will give you some information on when and where this infection typically occurs. Then I will discuss the diagnosis and treatment of PAM. Finally, I will tell you about ways people can help reduce their risk of becoming infected with Naegleria fowleri. Naegleria fowleri is commonly found in warm, fresh water such as lakes, rivers, streams, and hot springs. It has 3 life stages: an environmentally hardy cyst, a temporary non-feeding flagellate, and the trophozoite, which is the infective stage. The amoeba infects people when water containing the amoeba enters the body through the nose. It then travels up the olfactory nerve to the brain, where it causes PAM, which is usually fatal. Infection typically occurs when people go swimming or diving in warm, fresh water. In very rare instances, PAM may also occur when water from other sources, such as inadequately treated swimming pool water or contaminated tap water, enters the nose. In the United States, there were 143 PAM cases from 1962 through 2016, with 4 survivors. Most infections occurred in southern states across the country during the summer months, with more than half in Texas and Florida. PAM disproportionately affects males and children, maybe because of the types of water activities, such as diving or water skiing, that might be more common among young boys. 73% of cases have occurred in males, and over 80% have occurred in children 19 years and younger. Recently, cases of PAM have been identified in states as far north as Minnesota, Indiana, and Maryland, possibly due to rising average water temperatures. Although swimming in warm, fresh water remains the predominant risk factor for infection, in the last few years we have noted some changes in the types of water exposures leading to PAM. In 2011, 2 cases of PAM were reported from Louisiana in people who did not have a recent history of swimming in warm, fresh water. They were found to be regular users of neti pots for nasal saline irrigation, and apparently made their irrigation solutions with Naegleria fowleri contaminated household tap water. In 2012, a PAM case occurred in a man from St. Thomas in the U.S. Virgin Islands who performed ritual nasal rinsing with home tap water as part of his Muslim faith. The following summer, in 2013, a child who had played on a backyard water slide supplied with water from a home tap died of PAM in Louisiana. In all of these cases, Naegleria fowleri was found in water samples taken from the homes of the patients. In the 2013 Louisiana case, public health officials found Naegleria fowleri in water samples from the public drinking water system. Warm water and low disinfectant levels likely provided conditions that allowed for Naegleria fowleri to grow. Since these cases were identified, Louisiana has taken steps to ensure that adequate levels of disinfectant are maintained in public drinking water systems. These cases brought to light the possibility of Naegleria fowleri being transmitted by drinking water that enters the body through the nose. Now I'll spend a few moments discussing how people can reduce their risk for PAM. The only certain way to prevent PAM due to swimming is to refrain from water-related activities in warm, fresh water. Additional recommendations that may reduce risk include holding your nose shut using nose clips or keeping your head above water when taking part in water-related activities in bodies of warm, fresh water to stop any water from getting up your nose. Avoid putting your head under the water in hot springs and other untreated thermal waters. Avoid water-related activities in warm, fresh water during periods of high water temperature and low water levels. And avoid digging in or stirring up the sediment while taking part in water-related activities in shallow, warm, freshwater areas. A case in 2015 from California was associated with swimming in a poorly treated swimming pool. However, a properly treated and maintained swimming pool with adequate levels of disinfectant is safe and should not transmit Naegleria. In 2016, an 18-year-old woman died of PAM after she had fallen out of a raft on an artificial whitewater river in North Carolina. An investigation of the facility found multiple water and environmental samples that were positive for Naegleria fowleri. Conditions in the whitewater facility, including warm, turbid water with little chlorine and heavy algal growth, likely rendered their water treatment system ineffective and provided an ideal environment for Naegleria fowleri to thrive. These cases highlight continued changes in the water exposures that lead to PAM and the need for ongoing surveillance for these infections. I would also like to provide some background information about the clinical features and diagnosis of PAM. Clinically, a patient with PAM presents much like a patient with bacterial meningitis, with symptoms of severe headache, fever, vomiting, neck stiffness, and seizures. Studies of the cerebrospinal fluid, or CSF, from patients with PAM typically demonstrate a pattern similar to bacterial meningitis, with an elevated opening pressure, a polymorphonuclear pleocytosis, normal or low glucose level, and an elevated protein level. Brain imaging is usually unhelpful in the diagnosis of PAM because findings are often normal early in the course of the disease. When an abnormality is present, it is often cerebral edema. The most important clues pointing to the diagnosis of PAM in a patient with the symptoms just described lie in the patient's history. If, in the 2 weeks before presentation, the patient swam in fresh water, such as a lake, river, or stream, during the summer months, or performed nasal or sinus irrigation either for medical or religious purposes using tap water that was not boiled, filtered, or otherwise treated by the patient, you should consider the diagnosis of PAM and consult with CDC immediately. Initial testing should include a lumbar puncture to obtain CSF. CSF should be examined as described earlier in this video. Regardless of whether motile amoebae are seen, 24/7 diagnostic and treatment consultation is available through CDC. CDC can do testing including polymerase chain reaction, or PCR, to detect Naegleria fowleri DNA in the CSF. Furthermore, if suspected amoebae are seen on the wet mount, you can send images of the CSF under the microscope to CDC for examination by one of our microbiologists. Although PAM is nearly always fatal, there have been 4 well-documented U.S. survivors who received a combination of drugs with activity against Naegleria fowleri. This combination of drugs includes amphotericin B, rifampin, fluconazole, and azithromycin, which should be readily available in most medical centers. Miltefosine is also recommended, which may need to be ordered from the company that distributes it in the United States. If the patient has evidence of elevated intracranial pressure, clinicians should consider both critical care and neurosurgical consultation for aggressive management. Management of cerebral edema and elevated intracranial pressure in PAM survivors has included administration of steroids, drainage of CSF, hyperosmolar therapy, moderate hyperventilation, and induced hypothermia. You can see details about this recommended treatment regimen on CDC's Naegleria website. For 24/7 diagnostic assistance, specimen collection guidance, shipping instructions, and treatment recommendations, please contact the CDC Emergency Operations Center at 770-488-7100.
Patients diagnosed with PAM have a slim 3% survival rate. Unfortunately for Steve and Shelley Smelski, they found out firsthand how deadly this amoeba can be. They were enjoying a family vacation in Costa Rica when their son Jordan came into contact with Naegleria.
Life was perfect. I couldn't ask for anything more. I was truly blessed with an amazing, healthy child who was full of energy from the moment he woke up to the moment he went to bed.
Jordan was a wild spirit. You couldn't talk him into doing something if he didn't want to do it. He was pretty headstrong.
He had the most amazing smile and was a very, very happy child.
He liked doing things together. We called ourselves the Three Musketeers. We did a lot of things together.
So we had decided to take a trip to Costa Rica, and we stayed at 2 amazing resorts there.
So the last day that we were at that resort, Jordan was waiting for me, and he goes, "Dad, Mom's got a massage, and she's doing a pedicure, and it's just you and me. What do you want to do?" I said, "I don't know. What do you want to do?" He said, "I'd like to go tubing on the river." And I talked him out of it. I said, "It rained last night and the river's going to be cold." I said, "What if we go up to the hot spring that's got the water slide?" And he's like, "Okay." And I talked him out of going tubing to go in the pool. And he and I spent 6 hours going down that slide. He wore me out and he wore out several other people.
Jordan swam on Tuesday. We left the second resort on Thursday to head back into San Jose for our flight back to Orlando.
The headache started on Thursday. It was a down day. He didn't want to do much. Friday we got up in that morning and we headed back to the airport. We flew back into Orlando, and by the time we got the luggage and got through customs, his headache was pretty bad. He just wanted some takeout food when we got home. We gave him some Motrin, and we were a little concerned because it had been 3 days in a row and it had gotten worse each day.
By midday on Saturday, he was really having excruciating headaches, almost what I would describe as an adult might feel a really intense migraine headache. And he was just holding his head and saying that his head hurt really, really bad. And he complained that his neck felt stiff.
Got up Saturday morning, he seemed okay. He wanted to play his games. He wanted to get with one of his friends, have his friend over to play. And we're like, oh, you're tired, you just got back from the trip. Give it a break, and you got plenty of time for summer vacation. We didn't know that that would be the last day he'd play games.
So he was pretty much in bed that day. He just was not feeling well, and that was very unusual for Jordan.
By afternoon, he was just laying around. He didn't want to do much.
By Saturday night, he was still having really, really bad headaches, so I gave him some Tylenol just before bed.
We put him to bed, and he started vomiting probably an hour later. It started about 11:30.
The night was terrible. He kept vomiting on and off throughout the night. I took his blood pressure, took his temperature. He had just only a slightly elevated temperature. It wasn't a high temperature.
Shelly got me, and she goes, I'm concerned. He doesn't feel good. He can't keep anything down. I said, all right, we'll take him to the emergency room if he's like that in the morning. So I spent the rest of the night with him. He was up every 20, 30 minutes.
The next morning, he still wasn't feeling any better, so we definitely decided that we were taking him to the emergency room. And we did, and he was just so weak at that point. Ran some blood tests, and then I believe it was based on the blood test and the high white blood cell count, they decided to do a spinal tap. And when the doctor did it, he said, oh, you know, the good news is the spinal fluid is clear. And so I felt relieved just hearing anything that, you know, this was good news.
They did a CT scan after that, and they diagnosed him with viral meningitis. We asked, well, how serious is that? And he said, well, you'll probably take him home in 3 to 5 days.
You know, he seemed to kind of perk up a little bit, and he seemed to be feeling better, so that gave me maybe a false sense of hope that maybe he was doing better than he was. And I think, too, I felt like he was in the hospital, and, you know, the doctors were going to be able to take care of him, and he was going to be fine. No parent ever fathoms. I don't think that they're going to lose their child. You think that the doctors, you know, are amazing and they can save your child no matter what it is.
On Monday, which is 6 days after swimming, he got up and he seemed better. He still couldn't keep anything down. Said he still had a slight headache, and we weren't laughing and joking and talking about what we're going to do on the next vacation and what he wanted to do for summer vacation and where he wanted to go see his grandparents.
Monday, 4 or 5 o'clock, he was still having these horrific headaches.
I said, how bad is it? He goes, oh, it's a 9, Dad. It's really bad and it hurts.
They gave him morphine.
It couldn't have been 10 seconds after they started the morphine drip. His eyes, his pupils dilated.
He started having hallucinations.
He wasn't making sense, and then over the next hour and a half, he didn't say as much. He wasn't seeing as much, and then the uncontrollable shaking, and he'd flail his legs around and his arms around. He couldn't control them.
We were afraid he was going to rip out his IV, and then he started to have a seizure.
By the end of the 4.5 hours, he didn't know where he was. He didn't know who he was. He didn't know who we were. It was just a blank stare. And they brought the ICU team in just as he had a seizure. He had aspirated into his lungs. They got some of that out. Thank God that they were there, because we probably couldn't have got that cleared in time. And they went ahead and put him on another stretcher, took him down the stairs, 2 floors to the ICU. And they tried to get him stabilized, and they gave him some sodium. It seemed to settle everything down. They did it rounds in the morning, and the doctors came in and they said, Well, we've got him stable. That's good. Now it's going to be longer than we thought, but you'll probably take him home in 2 to 3 weeks.
But no worries, I was going to take Jordan home. So I just remember just wrapping my arms around him and thanking him because I couldn't fathom what it was going to be like if anything happened to my son.
Later that night on Tuesday, it got worse, about 5 or 6 o'clock, and his vitals started dropping. His left lung ended up collapsing.
There was a point in which in the room, the doctor just looked around at the nursing team and he said, I don't even know, anybody have any ideas? He says, I don't know what's, I don't know what's going on here. And at that point, I was like, oh my God, the doctor doesn't even know what's going on. And he was asking for ideas, and one of the clinical staff said, recommended bringing in a neurologist to look at, the fluid in the brain.
And finally they said the cranial pressure was so high that they were worried it was going to push down on the brainstem, which will actually kill him. And they said, well, we could relieve the pressure, so we gave him the approval to bring a neurosurgeon in. And he drilled and put a little drain on top. And they actually collected the fluid that came out as they were reducing the pressure. And in that sample is when they found the amoeba. We Googled it, and the third click we found out that it's 99% fatal.
So when they said that, I knew Jordan was gonna die. And so the doctor had told and suggested that Steve and I get some rest because we'd been up for several days during all of this, and because he said we were going to have to make some difficult decisions.
A normal person is 15 on a scale of 1 to 15 for normal brain activity, and Jordan's a 3, which is just above brain dead.
And he came in and he said it was time that we were going to have to make a decision whether or not we were going to resuscitate Jordan. And so many of my family and some friends had gotten there by then, and so we all got around Jordan's bed. And I asked if there was one person in that room that thought we should resuscitate him to please speak up. And no one did. So we waited a few minutes longer and Jordan passed away.
The drug was ordered from the CDC that they recommend for treating Naegleria, and it arrived at the Orlando airport 2 hours after Jordan passed. We let our guard down and didn't realize that swimming in hot springs was dangerous. He'd done it in 2011 and nothing happened. And it didn't even occur to us that it might be an issue.
The amoeba the water has to be forced up the nose, and apparently, with going down the slides so many times, that's where he was infected.
So we swam on a Tuesday. He died Wednesday morning at 6:35 a.m., 7 days and 12 hours after swimming. And we had to take him to the hospital by Sunday, so by 4.5 days, I mean, you're in serious trouble and you don't even know it.
Well, I think there's a lot of, what ifs. We found out that the resort knew about Naegleria, fowleri. So what if there'd just simply been a sign that said, this water is fed from hot springs or danger? And then yes, once you get into the hospital, right? What if they would have heated Jordan's spinal fluid? What if they had looked deeper to see if the spinal fluid had an amoeba in it? They could have immediately properly diagnosed Jordan, and then they could have put him on the proper path for treatment.
You say, what if I'd known more about it? Or what if there'd been a sign there? We wouldn't have let him swim because we knew it was 99% fatal.
I want to make one comment for parents. One day out of our 10-day trip for 4 hours. That's how I lost my son.
It's very easy to consider it rare. A lot of people say it, the press likes to say it's very rare. So it can make yourself very complacent. You can say, oh, it's not going to happen to me. Well, Shelley and I are here to tell you it certainly can happen to you. And if it does, it's going to rock your world.
So let's take a look at some laboratory techniques for detection of amoeba. It's certainly not unusual to receive a cerebral spinal fluid for testing in the clinical laboratory, especially from patients admitted to the emergency room with symptoms that point to meningitis. The typical test orders are for glucose, protein, culture with gram stain, and cell count. Protocol should dictate that these samples are handled stat. Since CSF is a hypotonic solution, cells such as neutrophils can lyse rapidly. When performing the cell count, differential, and the gram stain, we report what we see. But sometimes extra sample handling or manipulation is necessary to find things such as amoeba that may not be that visible or obvious at first glance when traditional laboratory testing procedures are utilized. Communication with the caregiver is critical when cases of meningitis are suspected, especially if primary amoebic meningoencephalitis is suspected. In these cases, it would be critical to know if the patient had had freshwater exposure in their recent history. At our institution, we've made this information part of our actual cell count order. When a patient presents with symptoms of meningitis, the physician is reminded through the laboratory order system to ask this question in the emergency room. When the order is received in the laboratory, the technologist can see the response in the result menu. The answer to the question is not mandatory, but the laboratory can still see this prompt each and every time they receive an order for a CSF cell count. This serves as a reminder to the technologist that amoeba could still be a possibility. The first step in processing of a CSF is to charge your counting chamber. What we're looking for in the CSF is the amoeboid movement of the trophozoite stage of the amoeba. A plain glass slide with a drop of well-mixed CSF that is cover slip can serve well also for looking for the amoeba. Contrast stains are not recommended for CSF cell counts, as these will kill the amoeba and you'll not be able to see any movement of the organisms. Warming the sample can enhance amoeba movement. Amoeba also become more active in warmer environments. The warming can be accomplished in several ways. A small aliquot of CSF can be warmed to 35 degrees in an incubator or water bath. The slide can also be warmed by allowing it to sit on the microscope stage for a few minutes. The light from the microscope can be enough warmth to encourage movement. This video shows a CSF sample that was plated into a standard plastic counting chamber for a cell count. You can see the size of the amoeba in relation to the chamber squares. You can also see the forward progressive movement as the amoeba works its way across the chamber. This movement was enhanced by allowing the counting chamber that was charged with CSF sample to sit on the microscope stage for a few minutes. Organisms may even be found outside of the counting chamber lines. The light source from the scope heated the sample enough to allow the technologist to view the characteristic movement of the amoeba. In contrast to the first video, this example shows a CSF sample that was prepared as a wet prep without the counting chamber. A plain glass slide was inoculated with a well-mixed drop of CSF sample and cover slipped. The sample was again allowed to sit on the microscope slide for a few minutes for the warmth of the microscope bulb to encourage movement. You can see that this amoeba, as compared to the amoeba in the first video, does not appear to be as motile. It could easily be mistaken for an artifact or possibly a macrophage on the slide if careful study is not taken and only given a quick glance. Oftentimes, these organisms can be mistaken for a white blood cell and are included in the nucleated cell count or not reported at all. Care should be taken to study all cell-like material to see if movement can be seen. The entire chamber and/or slide should be examined. It's also a good idea to video and/or photograph these organisms to educate staff. Other methods to enhance amoeba recovery include spinning an aliquot, a CSF, to concentrate the organisms. This can be accomplished in any standard centrifuge by spinning at 2,000 RPMs for 5 minutes. Also, amoeba can be encouraged to flagellate by adding a small aliquot of CSF to distilled water. Once the amoeba are first identified in a wet prep, the physician should be notified immediately. In addition to the wet prep, a cytospin preparation should be made on all CSF specimens. The cytospin serves to concentrate the cells and the organisms that may be found in small numbers. The differential can be performed on these slides as well as the identification of the amoeba. The right stain is used in hematology for differential analysis, and it is the right stain that is the preferred stain for identifying amoeba. Amoeba can be seen with a gram stain, but this is not the recommended method, as the heating of the slides in the gram stain process can destroy the morphology of the amoeba. The amoeba appears with a sky blue cytoplasm and a finely granular violet nucleus. Note that it is important to train technologists as to the appearance of the amoeba on stained cytospin preparations. An inexperienced technologist might mistake amoeba for macrophages or possibly lining cells. Once the presence of amoeba has been detected in either the wet prep or the cytospin preparation, the patient's physician should be notified in order to expedite treatment. This is of critical importance and cannot be stressed enough. The pathologist should also be notified immediately for confirmation. Infection control should also be notified at your facility. You'll also want to send a sample to the CDC where molecular confirmation will take place through PCR. If the organisms are found during the off shifts, it's important to keep the specimen at room temperature and not refrigerated before sending to the CDC. So now that you've seen the process, let's review best practices when dealing with CSF in the laboratory and a suspected case of meningitis due to the possible presence of amoeba. Utilize standard order code for amoeba exam. There should be an avenue for physicians to order an exam for amoeba if it is suspected when a patient presents with symptoms. This serves two purposes. This alerts the laboratory to utilize methods that could enhance amoeboid movement in a wet prep and alerts the lab to look for the appearance of amoeba in a stained cytospin preparation. This also allows for standard reporting to state agencies where required. Reporting of amoeba is required in the states of Florida, Texas, and Louisiana. However, in all states, the Centers for Disease Control and Prevention should be contacted anytime, day or night, 24/7 at their Emergency Operations Center at 770-488-7100 immediately when organisms are detected. Diagnostic support and treatment recommendations, as well as information to facilitate the shipment of a specimen to their lab for confirmatory testing is provided. It is important to note that the absence of this request from a physician does not exclude amoeba from the diagnosis. Amoeba may not be the first thought for diagnosis. The laboratory report may be the first indication that amoeba infection is present. A power plan for patients being seen for suspected meningitis should include inquiry into the patient's recent history and possible freshwater exposure. Communication with the caregiver is critical in these cases. Laboratory testing for CSF with urgency. Examine workflow processing within your organization. Time is of the essence with amoeba cases, both for recovery of the organism as well as initiation of patient treatment. Samples should be delivered to the laboratory immediately and testing begun as soon as possible. Cells will start to lyse in the CSF if testing is delayed. Avoid use of automation for CSF cell counts. Amoeba are usually first identified in the laboratory when technologists are performing a wet preparation in a counting chamber that has been plated to enumerate white blood cells and red blood cells. If automated systems are routinely utilized for cell counts, it is important to also perform a wet prep to look for distinctive amoeboid movement. This movement can be seen under the microscope as the organisms blend in with the white cells and the red cells in the counting chamber or on a plain glass slide. The addition of warm water to a drop of CSF in the wet prep will optimize visualization and increase the likelihood that one will be able to see amoeboid movement or the movement of flagellated cells. Avoid use of contrast stain when performing wet prep. Contrast stains are often used with body fluid samples to help differentiate between red cells and white cells for counting purposes and for cell enhancement in manual counting chambers. It is important to note that this contrast stain kills the amoeba and amoeboid movement will no longer be detected. The amoeba may then be mistaken for a white blood cell or even an artifact. Amoeba can stick to the sides of the CSF collection tubes. Make sure to thoroughly mix specimens and gently shake tube and flick the sides of the tube while mixing. Amoeba are more active in warmer environments. Active directional amoeboid movement can be enhanced for microscopic exam by warming a slide before or even after inoculation. The slide can be warmed in an incubator or by placing a warmed penny on the slide or even leaving the slide under the light of the microscope once plated. Allow slide to sit under the microscope for 10 minutes to warm from the heat of the microscope bulb. Amoeboid movement can also be enhanced by combining a few drops of warm water with an aliquot of CSF. The addition of the warm water will improve the opportunity to see the amoebas with microscopic exam because their movement will increase. The addition of warm water may also cause the amoeba to inflagellate and a swimming type movement may be seen. But inflagellation usually will not occur for at least around an hour, if it occurs at all, and so this is not the primary reason for adding the warm water. Greater recovery of organisms can be enhanced by concentrating a portion of the CSF as well. An aliquot of CSF can be spun down in a standard centrifuge at 2,000 RPMs for 5 minutes. Do not refrigerate or freeze the sample, as this will inactivate or kill the amoeba. Keep sample at room temperature if amoeba are suspected. Examine stained cytospin preparation. A cytospin slide should be prepared on all CSF specimens regardless of cell count recovery. In our facility, if the cell count is less than 5, a differential is not required, but we do require that the slide is scanned in entirety to look for atypical cells as well as amoeba and other significant findings. The slide should be scanned in entirety. Amoeba can be differentiated from white cells on right stained cytospin preparations, as the trophozoites present with a nucleus with a large, centrally located, and densely staining nucleolus. This large, densely staining nucleolus is an important distinguishing characteristic. The amoeba are 15 to 20 micrometers in diameter with sky blue cytoplasm and a distinct, finely granular violet nucleus. Gram stain should be avoided as heat fixation can destroy the morphology of the amoeba. Notify physician immediately. Pathologists should be contacted immediately for confirmation, and patient's physician should be notified immediately so that treatment can be initiated. Infection control should also be notified. Notify and send sample to CDC for confirmation. Sample should also be sent to the CDC for confirmation by molecular testing with PCR. Naegleria fowleri is a devastating disease. As you've learned, there are very few survivors. At this time, we'll hear how the laboratory awareness and early detection of the amoeba in the lab contributed to the only other documented successful case in the United States, in addition to Sebastian's since 1978. In 2013, Kaylee Hardig presented to the Arkansas Children's Hospital Emergency Department with a 2-day history of headache and a 1-day history of fever with nausea, vomiting, and drowsiness. She reported swimming in a local water park just 7 days before the onset of her symptoms.
Thank you, Sheila. My name is Frankie Johns. I was the evening supervisor in the laboratory at Arkansas Children's Hospital in Little Rock. I retired after 32 years of service. Kaylee Hardig was 12 years old when her mother brought her to the Arkansas Children's Hospital emergency room with a headache that somehow seemed different from an ordinary one. The ER staff quickly realized a lumbar puncture was indicated. I was not scheduled to be working in microbiology that evening, but was in the lab for annual competency testing. The tech on duty had gone to supper, so I was available to cover her area. When the spinal fluid arrived in the lab, I observed the milky appearance and realized this was what we call a hot fluid. I noticed the child's age and immediately thought this is either Neisseria meningitidis, which is a gram-negative rod, or Naegleria. I spent about 5 minutes looking at the gram stain and could see no organisms indicative of Neisseria. When the microtech returned from supper, I left her to review the slide more thoroughly. I then turned my attention to my suspicion of Naegleria. Naegleria are not very recognizable on gram stain because they resemble macrophages, which are a normal finding in spinal fluid. Because of my experience in looking at right-stained CSF, I immediately went to the hematology department to look at that slide. The cytospin slide was still in the process of being stained. I talked with the technologist that performed the cell count and told him of my suspicions. He informed me that he had not observed any motility on the counting chamber. This presentation was different from the cases we had previously seen. Prior to this case, the first indication we had of the presence of Naegleria was when we observed motile organisms. As soon as the slide was ready, I looked at it under the microscope and immediately saw the amoeba. I called the physician in the ER to inform him of our presumptive identification of Naegleria. The physician said that they were very sure Kaylee had meningitis but had not suspected Naegleria. Everyone involved feels that the quick recognition of this organism was a major factor in Kaylee's successful recovery. Much credit can also be given to Kaylee's mother for recognizing that something was seriously wrong with Kaylee and bringing her to Arkansas Children's Hospital. Sadly, her mother lost her own battle with cancer, but lived long enough to see her daughter's complete recovery. Our previous cases had all started with admissions to local community hospitals. The patients were treated as bacterial meningitis and were only transported to our hospital as their conditions worsened. For this reason, it is imperative that techs at all hospitals be educated in methods to suspect and recognize this deadly organism. I had worked at Arkansas Children's for 28 years as of that summer, and I believe experience definitely played a role in our recognition of this organism. I had been present for all but one of our previous cases. That was the year 2013 that I had intended to retire, but this case had such a profound effect on me that I continued to work for another 4 years after that, with one of my goals being to ensure all of our technologists were aware of the possibility of infection with the amoeba Naegleria fowleri in all suspect meningitis cases with CSF specimens. As you learned earlier in Sheila's presentation, as well in the video for Sebastian, the amoeba was detected in his case first by visualizing its movement in the CSF under direct microscopy. In our particular case, as you have just seen, the amoebas in Kaylee's specimen were first detected with the staining technique, specifically the right Giemsa stain, after no movement was observed under direct microscopic examination of the CSF. So you see now that the amoeba can be detected in two different ways. The one key aspect that both labs had in common was the awareness that infection with the amoeba in those suspect meningitis cases was a possibility. This awareness led to the rapid detection of the amoeba, which led to the prompt initiation of specific treatment for primary amoebic meningoencephalitis, also known as PAM. The prompt specific treatment resulted in successful outcomes, lives saved, with no central nervous system deficits. For many years, laboratories have been at a disadvantage in detecting the amoeba. There are three main reasons for this. First, because this infection has most often not been suspected, asking the patient about exposure to fresh water in the previous 2 weeks is important. Examples include swimming in a fresh body of water, use of a neti pot, nasal cleansing for religious purposes, or some other water exposure in the nose. This type of in-depth diagnostic workup has not always been included at the point of care or in the laboratory when a CSF specimen is received. The focus has always been on bacterial or viral meningitis. The second reason is that the lab procedures needed to detect the amoeba, that is, the wet mount for visualizing movement and the use of the right Giemsa stain, are not, at least in most labs, the standard usual procedures for CSF in suspect meningitis cases. The third reason that laboratories have been at a disadvantage in detecting the amoeba is that the usual go-to stain for CSF in suspect meningitis cases is the gram stain. The heat fixation used during the gram stain process can destroy the morphology of the organisms to the point at which they are more difficult to identify on a gram stain smear. The right stain uses methanol to fix the cellular components as opposed to heat, and the amoeba's morphologic characteristics are better kept intact. Quite simply, the amoebas are much easier to detect using the right Giemsa stain, as you will see in a moment. If only a gram stain is performed on a suspect meningitis CSF specimen in a patient with a history of freshwater exposure, then the amoeba could very easily be missed, as Sheila stressed earlier. Since laboratories are so used to relying only on the gram stain, and Naegleria infections can be missed, at this time I would like to demonstrate why the gram stain is not the stain for detecting the amoeba, and why the right Giemsa stain is the preferred stain for detecting the amoeba. The image appearing now is a gram stain of the CSF specimen from Kaylee. Can you pick out the amoebas in this field? Let's take a look at that same CSF specimen with the right Giemsa stain. Can you pick out the amoebas in this field? Now we'll take another look at the original gram stain image, shown this time with arrows indicating the amoebas, and the right Giemsa stain as well. As you can see, they are much more difficult to find in the gram stain than in the right Giemsa stain. In the past, to receive a CSF specimen in the lab and to process it not only for bacteria but for the detection of Naegleria, fowleri, is not a usual CSF specimen processing scenario. But in cases where a history of freshwater exposure is known or cannot be absolutely ruled out, it definitely should be part of the procedure. Another scenario where processing for amoeba detection should also take place, especially where the freshwater exposure history is not known, is when you see a large number of neutrophils and no bacteria on the gram stain. Since time is of the essence in the detection of the amoeba, we strongly urge all laboratories to have a prearranged standard operating procedure for amoeba detection when a history of freshwater exposure is known in suspect meningitis cases, and also when the history is not known or cannot be determined. First, everyone should be trained to be aware of the possibility of Naegleria fowleri infection and to ask the requesting clinician about freshwater exposure when a CSF specimen is received and that history and information is not available with the specimen or on the record. The procedure should include saving CSF for the amoeba detection steps. The lab should have the following protocol prearranged. Which procedure will be done first, wet mount or stain? Can both be done simultaneously? In many cases, the wet mount may be the first step due to lab workflow and resources. Next, which department will do the fresh wet mount to look for movement? Which department will do the right Giemsa stain? What is the time limit set for the results after receiving the specimen in the lab? Does the procedure and responsible department change according to the shift? That should be prearranged as well so that any capacity lab can handle the procedures during any shift. Just about every lab has the capability to do a fresh wet mount by one of the procedures Sheila described above. Ideally, right Giemsa staining would be available as well. Other stains which can be used to detect the amoeba include hematoxylin and eosin, or the H&E, periodic acid shift, or the PAS, and trichrome. Thank you.
In summary, treatment of amoebic infections begins with awareness, not only for public but for healthcare professionals as well. Awareness continues with early detection, which fuels further research to find effective treatments. Awareness saves lives. In Sebastian's case, as well as Kaylee's, it was a medical technologist that alerted the physician to the deadly organism that was causing the symptoms of primary amoebic meningoencephalitis that both patients presented with. Medical technologists are trained to report what they find in specimens that are sent to the laboratory. If the medical technologist is made aware that a patient has had a water exposure in their recent history, the technologist can incorporate laboratory techniques that may reveal the presence of Naegleria, an organism that may otherwise go unseen. Communication between the laboratory and the healthcare provider are critical. Continuing education for the medical technologists as well as in-house proficiency testing are critical to ensure that personnel are kept up to date as well as informed about organisms like Naegleria fowleri. Amoeba needs to be on everyone's radar in order for it to be identified and diagnosed in a timely manner. A diagnosis not thought of is a diagnosis not made. Thank you for watching this presentation. So now you know the critical role that you can play in saving lives from Naegleria infection with awareness and proper techniques for rapid detection in the CSF specimen. For example, gram staining will destroy the morphology of the amoeba and make it difficult to see under the microscope. Warming the slide will increase the motility of the organism and make it easier to see. You're now familiar with the steps and procedures that will result in rapid detection of Naegleria in CSF specimens. You're also now familiar with the do's and don'ts of CSF specimen processing for Naegleria detection. You know that despite the extremely high mortality rate, there are successful outcomes when rapid detection occurs. Your efforts do make a difference.
Time moves so fast, just can't make it last. Saying everything has a reason, it's hard to hear when your heart is broken. Moved on to a better place, God's plan in time and space. Everyone's saying all the right things, but my heart is still broken. But when you look up into the sky at the stars shining bright, then you will see Jordan's smile. Ooh, you will see Jordan's smile. Trying to understand, wonder if we ever can. But then I see your face, I think of you and my heart is open. And when you look up into the sky at the stars shining bright, see Jordan's smile. Ooh, you will see Jordan's smile. Ooh, do we ever really lose love? Do we ever really lose love? Or does it just become a part of us? A part of us. And when you look up into the sky at the stars shining bright, to the sky at the stars shining God's plan in time and space.